partnership. We know in general, right, that the healthcare data world can be really dense. Social services data, certainly dense, but then sometimes they don't speak together. These data sets exist often in separate silos. And so they leave us really scrambling, as we still are today, right, despite technological advances in this regard and a lot of networks starting up to help to cross-pollinate and inform our SDOH work. We still tend to struggle with coordinating to improve care and services. So what we're hopefully going to get across today are some helpful tips that really talk about just the basics. I'll go over some basics of screening to all the way up to service delivery workflows and MLPs. And then we'll hear from our subject matter experts about some efforts that are going on around the country, at least where they are locally, and I do see it replicated around the country, about ways to break down those barriers that keep that information siloed. And then we'll learn about some ways to overcome the barriers to integration by sharing successful models of information, as well as touching on some of those legal or policy considerations when you're thinking about sharing that information between healthcare and social services, which I'm going to just note includes legal services. All right, so who are we hearing from today? We are joined by Lara Cartwright Smith. She's actually a professor here at the George Washington University in Washington, D.C. We're also joined by Jess Holmes, who is at the St. Louis, or St. Louis, let me know, Jess and Paul, how it's said, but at the St. Louis Integrated Health Network, and Paul Sorenson at the St. Louis Regional Data Alliance. I kept this very brief, and by no means, though, is to discount their rich experience and expertise in these areas. We have actually uploaded to GoToWebinar their full bios, and so we want you to take advantage so that you can also feel free to reach out. They know those emails are forthcoming, but reach out, look them up, Google them, see what they are talking about, see what they've created. I'll be providing this overview, and then they'll go into their specific presentations. All right. So the overview, for folks who have been with us over several months, I just want to make sure we're level setting. What is the MLP? If you're joining us for the very first time, you probably haven't seen this before. I just want to reiterate this and emphasize. We're not just talking about embedding lawyers to provide those direct civil legal services, that one-on-one legal assistance, but we're traveling all the way upstream and going into the trainings, right, to really help to strengthen that health center workforce. That's what we heard about the last time we gathered with the Washington MLP team. Then we go into like the clinic level changes. Washington MLP team and others have also highlighted some of these effects. And I'll talk about how the workflows that we'll address in a second also help to create that clinical level change. Finally, right, this is where the MLPs are really going, and many of them have been here, but they're creating that systemic change, having those policy change strategies that really have an impact beyond just the individuals that are there, but also in entire communities, and in some cases around the country. So again, what are the MLPs? This is where you're embedding those lawyers into the healthcare team to create healthier patients, stronger health center workforce, and improved health equity for entire communities. All right, I'm going to roll through this quickly because if you've been on this journey with us, we are walking through the 9 conversations that are in the Health Center MLP Toolkit, so you can really lay that strong foundation. First, we've been here, right? We talked about what are the SDOH problems that you want to address. And we know there are basically about 3 different ways to do this. The all patients approach. There's the approach where you can look at all social needs, or all patients, all social needs. We went through that conversation in depth early on. If you're going through the toolkit, you know that we also talked about how many lawyers do you really need to meet the specific goals. Then we talked about how do you actually build it? Do you contract out for legal services? Do you build it right in? How do you really then integrate those legal services in the truest sense of integration? I don't want to say or get everyone caught up on the semantics here when I say the truest level of integrated legal services, because some folks are at the beginning stages and doing the referrals, and that is not to be discounted. The value of that contracted out referral is not to be discounted at all. It definitely serves a great value, especially for folks who may be in legal deserts. But we went through this conversation, and then we moved on to, well, the big question always from start to finish and sustainability and beyond. How do we pay for this? So the toolkit goes into great detail about how to have this conversation, what to consider, and what some health center-based MLPs have really tapped into in terms of funding and resources to start and sustain their medical legal partnerships. Right. As folks are having conversations about how to really implement this thing called medical legal partnership, we talked about this conversation that centers around what really amounts to your MOU, right? So you look at your MOU, and this is where you've outlined the goals and expectations for the program. What does it mean for you as a healthcare partner? What does it mean for your legal partners? You're defining the purpose and the scope, formalizing the roles of each partner, and then measuring and conveying the value. Just going to say that one more time, that last one, because that goes into where we're going next, measuring and conveying the value. We then went into a little bit of highlighting of what other partners in the community can be helpful. This is an absolutely necessary conversation, right? Because in the spirit of partnership, you want to make sure that you're looking at the full breadth of services or resources or determinants that really affect that patient or client in the community. But once you have that conversation about what other partners you're going to be involved with, even if it's just that health and legal partner alone in that MOU, you end up landing on that conversation about what about the information that you're sharing and how do you address patient consent. And then finally, once you've had those conversations, and I'll go into depth into this because this is exactly where we're landing next, how do you really integrate this into your workflows and systems? You can't just get the consent and just like tap anyone to do the data gathering, the screening. You really have to think about the workflows. So I'm going to dive into that aspect and then go to my colleagues in the field who are the subject matter experts to talk about what models they've carried out and then what else you should be considering. So in implementing the workflows for screening and legal services, where you're having some of the first early questions really is at the start for everything about data, consent, and workflow. I was going to highlight on this chart straight out of the toolkit about screening and service delivery workflows. I was going to make a point about really considering data aspects at different points, but really I just want to highlight that it starts right at the start. You should be considering the consent, the information, the different people involved, the cost, how disruptive or helpful this may be right at the start, where you're thinking about designing your screening questions and then implementing the screening process. And typically, and this is what this flow chart represents, you really are in a medical legal partnership starting with your screenings first. And there are several examples in the field of like Prepare or Health Lead, so screening tools that have been created for gathering those social needs that amount to legal needs data. There are lots of those tools out there in the field. The next set of workflow issues you're looking at is typically the legal services. So once you've screened for and documented results, and then we think screened positive for a legal need, that's when you begin to think about, well, depending on how we decided to actually address social needs, what are we going to do next? How are we going to actually refer that patient to a legal team? Are we going to have a curbside consult? Or are we going to actually go to the direct legal services? Are we going to actually do a clinical level solution? Have we, through screening, uncovered a community-wide concern that we could really have a policy level solution to be able to address? Then the next area of workflow considerations goes really into the follow-up. So this is a lot of the work that we see from experts out there in the field about what happens once that that screening to legal intervention is completed. What happens next? What does the lawyer or the legal team do, whether or not they were able to resolve the problem with actual direct legal services or by providing that counsel and advice, or perhaps they were in need of actually referring that individual to someone else in the community. Sometimes there isn't a legal intervention and perhaps it's just informing someone of another resource. Once you move beyond the follow-up, and presumably, right, you've got all of this data continuing to flow and it actually loops back, right? You are in the stage of then going into quality improvement. So that's the evaluation aspects. That's where you're really looking at whether or not all that you've done from screening to services, follow-up, did it actually create a change? And hopefully you had your measures in place as well so that you collected the right data to go into this. Did you actually create a change? This is whether it's positive or negative, you're actually evaluating impact. And then in addition to evaluating the individual impact on the person you helped or in the community, you should also be evaluating this entire process from screening all the way through to that evaluation. How did you build your evaluation into the entire process? So I really wanted to walk through this particular screening to service delivery flow chart in detail so that you could really have just this in mind as we hear from Paul and Jess and Lara about some considerations and models. This is the high level version that I'm presenting, and you'll hear in detail from them about what the different approaches look like in the systems or the workflows that they may present. In general, we do see that there are about 4 different approaches to screenings, where you can have the self-administered by the patient or the non-clinical, or you can have the clinical staff person, some hybrid, which is less common, or perhaps you have that high-level screening that is also looping that data into the EHR and back. That's the ideal. That's what we're working on next. The types of questions, I built some of these into the slide deck. I'm going to just quickly highlight just a few of these. But one of the considerations when you're looking at your screening tools is, first of all, always ask at the outset, why are you considering screening at all? And I want to stick on that point for a moment to just say, where we are next in terms of screening is really looking at like whether that data is being either sent to or collected by the EHR. We're trying to connect this data to EHRs. So I think it's really, really crucial that folks ask, why are you considering screening? That way you try to have that conversation early on with your healthcare partners to see, are they doing the screening by virtue of some questions that they're asking in the EHR? Is there something you can do to not have to build on the outside, but build things using what they already have in place? On the screen is a screenshot. On the screen is a screenshot of Siouxland Community Health Center's EHR legal screening tools. And you can see one of the questions they ask, it doesn't say, hey, patient, do you have a legal problem? It really just amounts to whatever the patient is really going through. That may translate into a social need that can be addressed through legal intervention. So what's on the screen falls into the bucket of income and insurance. And the example we highlight, and this is also in the toolkit, are your wages being garnished, or do you have concerns about debts? Because we know these are the sorts of things that can result in a legal issue such as bankruptcy or debt collection or predatory lending, or perhaps unpaid or underpaid wage claims. And maybe that's what's really playing out. All right, so I talked in depth when I showed the workflow about the patient referrals, but the types of information that are typically collected when you're doing referrals are patient names. The referring clinician is really helpful. Having any sort of clinical diagnoses, because this goes into your outcomes evaluation to see did or try to show that your legal intervention actually created some some change in the health outcome. And then you're also looking at some clinical notes. Those are particularly helpful because the EHRs may not have the exact fields always built. So it's totally fine to say, hey, I need to look at clinical notes about some potentially unmet social or legal needs. And then, of course, there's the lawyer, where the lawyer gets involved, and you're really looking at when the lawyer's connected. This is the sort of data that you're collecting, right? Whether there was a false positive, and then finally all the way up to legal outcomes, making sure that on the legal side, it's really important. And I hated case management and updating that software, you all, when I did this. But it's really, really important, especially in a medical legal partnership where you do have to show ROI and show the full breadth of the social needs that were addressed, especially with these other partners involved, CBOs throughout the community. You really do need to document those legal outcomes. All right, so this is just a quick graph to show what this really looks like. And it pulls again from the graphic that we showed before about the outcomes of patient referral and intake. And then I have listed on the screen some of the different types of, in an easy like overview chart here or list. Health center data just aligned with legal partner data if you're looking at the continuous process of quality improvement. And then same thing for program evaluation. You have different types of data that we're recommending that you would collect on screening and referrals, legal services, and then outcomes. All of this is in the toolkit, everyone, so don't think that I'm rolling through these slides in any way. That would cause you to miss information. Also, we're definitely going to be sharing the slide deck after we're done with this presentation today. But I'm circling back to that graphic because at every single point, this is where you'll really hear from Paul, Jess, and Lara. At every single point of that workflow, you're collecting data. And what I also suggest here is that there are data elements that you may not even see or consider along the way. Metadata, when you're talking about files, right? Then there's the reverb effect. So I just wanted to loosely term that reverb data. And then we're in the space where we're doing a little bit of predictive analysis, right? So think about the things that you may need to or anticipate, or what you might be creating down the line. All right, so what Lara in particular will talk is really like the patient consent and information sharing. What are the legal considerations? And I just want to highlight a couple of graphics here to show you like how this typically works when you're looking at it in some sort of graphical sense here. So the schematic on the screen here, the basic one with the referral network shows medical and legal partner. In between there, though, you have an individual, or you can have an individual who's really coordinating this referral process. And don't forget that person is also sharing that information and data the patient, right? If it's an actual staff member of the MLP. And then finally, you also have a system. The easiest example I usually point to is Whitman Walker Health Center in Washington, D.C., where it's all built into one, but they are in fact still sharing different types of data that may come under the different auspices of different bodies, policies, or different types of laws. Again, there's data showing up everywhere. All right, so we do have some graphs in the toolkit. I'll just note this particular one actually comes from an issue brief that Professor Lara Cartwright Smith and her colleagues helped us to put together that really talks about these different data points where you may want to consider consent. On the healthcare side, when you're talking about that HIPAA covered information, on the legal side for the attorney-client information and the outcomes as well. And then Lara and Paul will highlight, that referrals data set, right, for those CBOs who are out there in the communities, and how many places patient consent may come up. Right, so I've talked about the CBOs. We've got some here with us. These are the folks, right, that you are talking to in the communities, whether they're PCAs, HCCNs, ACOs, state Medicaid agencies, MCOs, right? All of these are the folks that you are engaging, I would say, not just in the planning stages, but all throughout implementation. And if these dots aren't connecting, you very well may be missing data. If they're connected and you're not getting patient consent, you also may be missing some critical steps, and not just respecting the autonomy and agency of your patients or clients, right? But you're also, you could have some sort of compliance issues on your hands. So with that, I'm going to transition to hearing from our first expert from the field, Paul Sorenson from St. Louis Regional Data Alliance. Paul, just cue me up to advance your slides, and I'm happy to do so.
Perfect. Oof. So much fantastic content. I'm going to have to review the toolkit all over again and thinking through some of these things as well. So thank you for having us. Today what I'm going to present, and then what Jess will follow up on in part is what's going on in St. Louis. Helping to connect the dot between a variety of social services, community-based organizations, which do include legal services, with some of our CARES Act work now, but then sort of looking into the future. And then because in our conversations in St. Louis, oftentimes discussions with folks, who are, lawyers trying to provide legal services in the space, people are asking some very pointed questions about data governance and data sharing, which we'll also want to touch on because I think this is also a good audience to do so. Advance the slide. Perfect. So the St. Louis Community Information Exchange is an effort to connect health and social services in pursuit of whole person care here in St. Louis. It is sort of grounded by 3 backbone organizations. So it's led by the United Way of Greater St. Louis, particularly their 211 team that play an ongoing sort of referral role here in St. Louis and across the state of Missouri. Us as sort of the data backbone, trying to understand how all of these different pieces that fit together. And then Jess representing the St. Louis Integrated Health Network and her team, trying to understand how to best align the dots between health and social services with a lens to health equity and connectivity. So, you know, basic premise, right? Like someone has a concern, instead of like it always being sort of one-to-one, sort of like someone is given a post-it note with a phone number and saying good luck. What we want to do is make sure that data is connected and things that can be shared as seamlessly as possible in the pursuit of holistic person-centered care. And so our effort has been up and running in conversation for around 3 years now, but we really accelerated over the course of the past year during COVID. And particularly have been using some of the mechanisms that we've talked about today in administering emergency housing assistance funding as part of the CARE Act, which included a lot of eviction prevention, in which legal services played a very active role. And so happy to talk more about the CIE as a whole. I think the important things to know is that it encompasses regional partners. It is across health and social services, which include legal services. And it's actually right now driven by community-based organizations, driven by social services, not by healthcare, which for a community information exchange is a little bit atypical, given where a lot of the funding for this work comes in. And so this is who is involved sort of so far from a big picture standpoint. And, you know, I didn't really want to throw another diagram at you, especially given all the really good ones that MLP have created, but I'm going to pause on this slide real quick just to sort of discuss the workflow that we have been implementing and testing as part of the CARES Act funding here in St. Louis. So the CIE and particularly United Way, sort of using this Unite Us referral platform, which I can talk about a little bit more in a second, we're responsible for helping to connect folks to emergency housing assistance dollars that were coming through the St. Louis City and St. Louis County governments. And that process really sort of got us into thinking about, okay, so here's a person who identifies a need. I know in the previous examples, it was sort of coming from a clinical environment or coming from a legal environment. How do we best understand in the most respectful, person-centered way sort of what their concerns are, walked through an informed consent process that allowed their data to be stored and shared in a HIPAA-compliant system, and then connected to the best fit partner depending on the need. The way that folks decided to roll this out in St. Louis City, St. Louis County was through a network of community-based organizations, I think just also including IHN as part of that network. And so, you know, data was sort of shared in that system, and then those organizations would follow up directly with the individual. And so the last thing I want to mention on this slide, which I think was really interesting, is that our, as part of this eviction prevention sort of ecology, legal services were very present, right? Especially in some of the eviction prevention, like making sure that, especially when moratoriums were in place, people weren't being evicted without or just people weren't being evicted, period. And what came up in the legal services space, or anything sort of that touched the criminal justice environment, was like these really pointed questions about consent, about data governance, about data storage, about why you're collecting this information and who has access to it for what purpose. And so what I'm going to spend most of my time on after the next slide, just giving you a little bit of insight into the referral platform itself, is how we're approaching some of those bigger questions, because I suspect that a lot of you will come up against them sooner than later. So if you go to the next slide real quick, this is sort of how we are approaching this as like a simple workflow standpoint, sort of in collaboration with Unite Us. So this is a Unite Us sort of slide that they use in their demos to describe, you know, there's someone who is diabetic, who is, you know, either through a homeless shelter or through a hospital, and a discharge manager sort of use this care coordination platform, which has screening tools. Here in St. Louis, we're exploring the use of a simplified version of the Arizona self-sufficiency matrix to sort of get a better understanding of like multiple domains that folks may be looking for resources to address. And then people are sort of referred in a closed loop sort of way. So what we mean is it's not like, you know, a phone call into nowhere. But if someone is referred to an organization, the organization said like, yes, like you know, Joe is at my door, like we were able to provide services. And so the like referring body sort of knows that like, hey, this was addressed and this is something that can be successful. So again, like we can talk more about this. I know our contact information is included in the presentation, but what I did want to do for most of this time today is zoom out a bit more. When we talk about the core components of these data sharing systems, that address, you know, these social determinants of health, that address community service needs. And one thing that we have found to be a little bit tricky in the space, and certainly something that we encountered early on, is that people sometimes have a good understanding of like, what do information and referral systems do? Like a 211 where you call a phone number and someone provides information about like, hey, the service exists. And we know how like EHRs work and like a little bit in the health information exchange space about how data gets from one place to another. But if you're talking about this broader, more complex ecology of health and social services, and especially the social services side, there's just a lot of shared language that we were missing around what this could look like. And so myself at St. Louis Regional Data Alliance and our team, alongside a national organization called Open Referral that's been working with open data standards for 211s and others throughout the country, we're working on a white paper, and I'm going to send a link, and maybe folks can chat it out to learn more about this white paper, which will be released very soon in collaboration with data across sectors for health on defining some of these core components. So there's resource data, right? Data or information about resources available for people in need that need to be exchanged. So how do people update information that like, yes, we do have an attorney that's available, or like, yes, this food resource is not expired. You know, that actually becomes kind of difficult to manage across systems. So how do you do that most effectively? The thing that's the stickiest from a data exchange standpoint is like client or patient data exchange, especially when you get into this like responsible flow of information. Okay, so how do you do this responsibly? Information about clients shared among and across various kinds of service providers that may be under different privacy rules and may be more concerned about privacy, right? Like, you know, there are all sorts of different tensions to navigate here. And then all of this under an umbrella of community data governance, if you want to go to the next slide, that I think is really where we recommend people, I think, both start and persist as strongly as possible throughout their exploration. So what are the rules pertaining to the collection, storage, exchange, and use of data that are enforced according to the express interests of the variety of stakeholders, and really wanting to underscore sort of like in a local community, making sure that people have a sense of like, well, my data, right, and these services are not something that's being, you know, fully dictated by state funding bodies or payers or other folks there too. So, you know, there's a lot to dive into here. What I wanted to do is just sort of say, like, encountering this work, we'll sort of immediately throw these questions of like, wait, but who has access to what information for what purpose over what time period that we think are really, really important. And we also think that folks like you all have a good role to play in sort of pushing on efforts like ours in defining these things for the ethical sharing of data over time. So the next slide, I'm not even going to get into too much, right? Because this is like a quote unquote simplified landscape of all of the different pieces around data sharing that sort of come together when you talk about these systems. So you have the psychology of health information exchanges and their connectivity to EHR systems and healthcare providers. And you have these things, this like emerging conversation around community information exchanges or other places in which social services and client data can also be shared. And then how do you make sure that that can be both local where it needs to, as well as sort of, you know, connect to bigger networks? There are a lot of questions to dive into. And so, you know, the final sort of piece that we wanted to suggest was some different lenses to be approaching this data sharing conversation as you look to address it sort of in your community and with your efforts. One is, what impact is sharing data having on the individuals who are trying to access services? So issues around consent, right? It can't just be a toggle switch. It can't just be something that is, you know, you give your data and you don't know where it goes, and then who, you know, over time that becomes really complicated. And then understanding this role of like a person having full control of their own data may not actually be the most equitable thing to do if they can't grasp all the complex information behind the scenes. So there's a sense of stewardship and autonomy and ownership, right, that come together when we talk about design, we talk about leadership of how this impacts individuals. Impact on providers is also really important, especially when we talk about healthcare and social services, and making sure that healthcare just doesn't always govern the day. And so what are the incentive structures across these providers? How responsive are they? What technology systems are they using? Because that's very inequitable as well. And that ends up having a big implication on how we set up these systems. And then finally, how are we using them? You know, and Bethany mentioned like the metadata concerns and the predictive analytics and like how these things are informing how resources are allocated and policies are pursued. Like that has a big impact as well that needs to be considered at the beginning. And the screening tool, which collects some of that information, is often a place to really put some pressure on it. So I'm going to leave you with some questions that we're thinking through and then pass off the mic. I think I've stayed relatively within time. There are just tensions in this space, and you will encounter them if you haven't already, between the interest of individuals, providers, technology vendors, system actors. And I think the thing that we want to underscore is that its resolution may not always be possible or ethical, right? Like if you're resolving a conflict to make it easier for a technology provider, but like not for an individual, like you've done something wrong. But there is a balance too. And so how do you manage this tension over time? How do we understand how community-based organizations can participate in these systems, given that their care models are different? It's not like an individual service sort of like rendered just for an individual at a point in time with a code, right? Which I think oftentimes is how healthcare operates. So how can we be more family-centered, community-centered in our approach, especially when we're talking about centering equity and, you know, patient or client experience, and really just not confusing data governance considerations to be what you do when you choose one platform over another, and all this like other stuff around data trust and collaborative models. So we're going to throw a bunch of other things at you. My contact information is there. I'm going to send a link to find out more of this white paper if folks are interested. And I'm going to, I think, hand the mic back to Bethany to hand it to Jess.
Yes, thank you so much, Paul. So folks, don't forget to type your questions into the chat box. And Jess Holmes is going to speak next. Jess, just let me know when to advance your slides. And thanks.
Okay, thank you. I'm ready. So good afternoon, everyone. I'm really happy to be joining in this exchange with Laura, Paul, and Bethany. Today's topic is really about breaking down silos, and my belief is that silos are often unintentionally reinforced, either because we're not transparently sharing data or just sharing information, so just trust is fractured, that we are not planning to really map out the nuts and bolts of a strategy with intention, or that oftentimes we don't really build out the necessary buy-in so that we have adoption later down the line with our robust group of partners. So these are actually many of the reasons why the St. Louis Integrated Health Network was formed. And today I'll just be sharing more about how we advise our health center partners, but then also our larger partnerships outside of healthcare in how to build cross-sector initiatives. So on the slide that you're looking at, this is just a little bit about the IHN. We were formed in the 2002 timeframe, actually as a health center controlled network. But our focus was not really on becoming a shared data repository or a place where we would share things like an HR functionality. Our our community health center governance at the time really wanted IHN to focus on building clarity and collaboration with our large hospital systems. And at that time, trust between our health centers and our hospitals was fragile at best. So it took quite a bit of time to build trust between those entities. So over time, in the 2016 timeframe, IHN actually made a deliberate decision to relinquish its health center control network status, but not its mission around health center and safety net advocacy. And the reason we did this is we wanted to make room for our health systems partners to formally join our board so that we were participating in collective strategic planning together. So you'll see some of the key functions that we're playing a role in right now in leading this St. Louis health safety net. But you can also see from this map on the screen that the complexity of this map really for me represents the web of translation that our IHN team does for the safety net. So IHN's role is to really focus on and align strategy within our health system, but then also with other sectors like social services, education, or the business community. And we are centered on focusing the proper attention and the proper just dignity and respect to safety net populations. So you'll see like we raise up health equity, we raise up the safety net, we raise up our health centers. You can go to the next slide. So what we wanted to do today from an IHN standpoint is really just share some of our lessons learned in how we have built these partnerships over time. A lot of the partnerships that we've built out are focused on care transitions between institutions. They're focused on addressing social determinants of health, and then building the mechanisms for how that work gets done. So we are huge champions of the community health worker workforce, for example, in the St. Louis region. And so this checklist is really what I prepared to just share some lessons learned that I hope will accelerate your success as you build out these partnerships. So for us, the most, and from my just experience, is that the most innovative cross-sector partnerships for me tend to fall apart in somewhere in between where strategic planning needs to jump to implementation all the time. There might be like a really wonderful idea out there, but then the nuts and bolts don't get built out in the right way. And so what I also want to just really say loud and clear, like shout it from the mountaintops, is that the hard work that you put in on thorough planning on the front end will set you free later. The toolkit that you have from MLP, read it and use the questions, use the structures, because it will free you up to focus on other important things rather than crisis and reaction management because a plan wasn't properly put in place. I can't tell you how many partnerships I've seen dissolve because of hurt feelings or frustrations, just simply because roles weren't clear in the arrangement of the partners. So the IHN has a strong track record of building these partnerships, and the first place that we start is by just scanning our environment, our external environment. So just a side note here, if you are a health center leader, I highly recommend that you check out UCLA's healthcare executive program. They have these, like the greatest business leaders in the world at UCLA sharing their expertise with safety net leaders. And this is actually the first thing that they teach us. This is where they tell us to start, is environmental scanning and environmental mapping. So, you know, part of why environmental scanning is so important is that it builds momentum and energy around your initiative. And actually each of these steps in the process, to me, underlying them should be building buy-in with stakeholders along the way, building the buy-in with all the partners, making sure expectations are clear. So the value of doing some environmental scanning is you get a sense and gain intelligence to inform your strategy and inform your model. Like what technologies are out there, what are their limitations, what has not worked with the data that you can maybe provide a solution to, what other partner tables are out there that are maybe already doing work and you can, you know, make it so it's not duplicative. What's the political climate, and then where can you identify who your champions are and where there's resistance so that you can manage it. And these pieces seem intuitive, but they do fall apart. They're easy to miss if you don't structure this in a plan. So on the next slide, I'm just sharing a couple examples to Paul's earlier presentation around our community information exchange work. This is how an example of how the Integrated Health Network is weaving together strategies so that they are aligned and focused and mutually reinforcing one another, so that we are getting, you know, getting to outcomes faster for our patient populations. So we already have some care transitions infrastructure between our large hospital systems and our health centers. And then we are huge active champions for scaling a community health worker movement, not only in St. Louis, but across the state. And while we're doing that, we're promoting social determinants of health with our IHN network partners who are working on health needs assessments or, you know, improvement plans at our health departments, at our hospital systems, so that we're building the natural alignment in the health system. And this is all in connection to the work that we're doing in partnership with Paul at the Regional Data Alliance and in the United Way to have more transparent data and connectivity across our system. So literally, I will take a map like this and I'll put it in front of our board members. I'll put it in front of our stakeholders. I'll ask them to, you know, really scrutinize it, and it helps us build alignment about where we're going. So the next slide is another example of that, where throughout these interviews, what we do is kind of collect information about what people are seeing, how they look at a map like this and think about, you know, where they fit, where it might break down. And we do this with executive leaders across our healthcare sector, and then also with external partners, and just start mapping themes of the current environment. And so I'm not going to walk through these per se. I'll just give an example, though, that in the time of COVID, there's a huge shift in our health systems mentality right now, where they're looking away from emergency response in hospital settings to upstream shift in medical groups. And so those types of things are really helpful to us because they inform us where there are strategic points of intersection across our networks and across our partnerships. So the other one I'll just call out, just because it's interesting, is around this added functionality that health centers are playing to be public health agents and not just primary care providers. And what does that do to their capacity right now? When's the best time to, you know, introduce the concept of a community information exchange, that it will add value to them and help them make their work easier because of how stretched they are right now. So these are just some things that these kind of interviews help with. Next slide. So there's a couple of areas here around feasibility and scoping that I think I'll just really quickly in the middle blue column before we jump to building consensus, that the MLP toolkit I think gives really helpful framework around. And why this is important is really about expectation setting with your partners. We have managed care organizations, for example, who reach out to us requesting partnership. Like maybe they want to hire a team of CHWs and do it through the community or through the IHN, or you know, just other pieces like that. And how we envision that work actually looks very different from how they envision that work. So how are we having an exchange and conversation and really making sure that we understand that, so that again, the partnership doesn't crumble on the back end. The other place that I think about this is around electronic health records. And, you know, right now the frustration in a lot of places is around duplicate entry. So the purpose of the upfront screening tools that Bethany mentioned earlier, like, do you really need to screen? That becomes important in terms of buying to your team. So this next piece, and actually the next two pieces, are really about building buy-in with your team, like who's going to actually be implementing the work. And there's some suggestions here around, you know, just getting clear on priority populations. What does the intersection of the referral look like at different points? And that, I'll jump to the next slide. I just want to show you another example of what we've done. We have some work that we do in the justice sector where we connect our justice sector leaders with our healthcare infrastructure. And we do that through a CHW functionality along with a network that we pull together. And so we will use maps like this. Again, cannot underemphasize the usefulness of visuals. We will use maps like this to bring partners together at a collaborative table and just start filling in these process maps. And it helps everyone get on the same page. It helps everyone ask questions about their role and get clear on their role, not just from the executive lens, but the team lens as well. So those were just a little, you know, a couple models that we really wanted to share with you today to help you see and think about considerations for these types of partnerships. And happy to answer any further questions. But thank you so much, and my contact information is available to you as well.
Thanks so much, Jess. So we're going to transition to Lara. Again, another reminder that folks should be typing their questions into the chat, and then once Lara Cartwright Smith is finished with her presentation, we'll take some questions that may have come in. April Daniels will be reading them out. Lara, thanks for joining us. Let me know how you'd like me to, and when you'd like me to transition the slides. Thanks.
Great, thanks. Thanks, Bethany. I'll try and go fast so you all have time for questions. So Bethany mentioned the brief that my colleagues and I did is about different models of sharing information in MLPs is in your toolkit. So I'll skip ahead actually on this one. Would you advance just 2 more slides actually? I can go fast. There we go. So, you know, both I think Jess and Paul mentioned that there are a lot of forces that are driving interest in sharing between social services and healthcare. And so this is not a new thing. Value-based purchasing and other forces have been incentivizing that sharing. But I think we're at a moment now where there's a lot of policy there's a lot of policy momentum going on. So there's been interest in this, and you can see even changes in the common rule in 2018 included thinking about allowing people to share information longer term or across settings of care, trying to get to outcomes data, patient-centered outcomes research, things like that. So allowing broad consent, for example, within research to allow the sort of research across settings of care to show value, to show savings, to show outcomes, return on investment. Definitely there's a lot of interest in this at the state and the federal level. Some states, for example, that are working on it, California, for example, has done some work to facilitate sharing of substance use, sharing information with between healthcare and providers of substance use services. And also now they're looking at food service providers. And so getting those connections, getting those bridges, the kinds of things that are going on in St. Louis, I think lots of communities are realizing the value that's there, and that momentum is changing, you know, helping change the policy conversation as well. At the federal level, 2 big changes that are happening right now is that the 21st Century Cures Act included requirements for interoperability that are designed to help support patient access, to facilitate patient access, and also to penalize information blocking. So try to unlock the data and help patients get access to their data and use it in a way that they want, whether it's in their particular health record, their app, or sharing with somebody else's information, being able to direct that information to go to whoever they want it to go to. But still, it was very patient-centered, patients are the hub. And right now, I really wanted to draw your attention to the proposed revisions to HIPAA. So there was a notice of proposed rulemaking in January that sort of at the very end of the Trump administration that came out. The comments were due in about 10 days, and then they extended them to May. And so I wanted to focus on this because there's some pieces that I think are obviously really relevant for you, but the HHS would really benefit from hearing from the health centers that are doing sharing social services data, working with legal partners, either whether you have an MLP or you're just thinking about the kinds of information that you would want to share to support your patients and your clients. I think it'd be really important to comment on these these proposed regs if you haven't. So I'm going to take a minute to talk about those. The proposal has a number of provisions that would help support patient access and allow patients to, for example, walk into a doctor's office and take pictures of the record with their phone and that sort of thing so that they can take it and share it with whoever they want, or also to direct their doctor's office to, or hospital or health center, whoever, to give their information to some third party, like say an app or something that they have. So it's empowering the patients in that way. But as Paul said, having the patients have to be the hub and be the ones who are responsible for taking their information and getting it to whoever they want to share it with. It can be really burdensome. Legally, that's sort of the workaround. That's the easiest legal structure, is to have somebody get all their records from, say, their substance use treatment program and own it and take responsibility for it, and then give it to their social worker or their parole officer, whoever they need to share it with for purposes of social services. But that puts, a lot of burden on the patient. They may not be able to keep it secure. They might not really understand what the rules are, what they're having, and all that information can be challenging to manage. And so legally, even though that's the workaround, it's not necessarily the best way for us to structure the process of information sharing. So the HHS is proposing to add a new express permission for covered entities, which would be health plans or healthcare providers in this case, to share protected health information with social services agencies, community-based organizations, home and community-based service providers, and other similar third parties that provide health-related services to specific individuals for individual level care coordination and case management, either as a treatment activity or healthcare operations activity. So I bolded those terms that are not defined in the proposed rule, because that's where I think there needs to be a lot of clarification that might be needed. So these are anticipating individual level care coordination and case management, so it might not necessarily reach the population level sharing that one might want, but it is a substantial expansion of how HIPAA works and the kinds of information that can be shared from covered entities. When the PHI would get disclosed to a third party, like a community organization, it would no longer be protected by HIPAA. It would be outside the bounds of HIPAA. So if the information is going to a non-covered entity, so like if it's going between providers, they can share whatever and it's covered. But if it's going outside, it would be outside of HIPAA, and then it could be redisclosed, given to somebody else without any protection for the patient. So that's an important distinction there. The minimum necessary standard would apply if it's being disclosed to a non-covered entity. So if it's going not to a provider or a plan, they would still have to share minimum. They would have to, share just the minimum necessary information, but that's up to the provider to determine what's minimum necessary. And so I think there's a lot to be considered about how that that rule might roll out. But I think they really would benefit. If you haven't commented already, I really encourage you to comment to think about how this would work in practice. They also would clarify that operations for purposes of health plans, that operations would not just be limited to population-based activities. So individual care coordination and case management activities the health plan could do under their operations definition, under this definition. One challenge with that, though, is the operations limitation for HIPAA has to be about the operation of the entity. So, thinking back to that drawing of the different models for information sharing, when it's one organization, of course, it's a lot easier to say this is for our benefit, it's our quality improvement. It's we're reviewing the outcomes of our processes, as opposed to something that's more community-wide. Next slide, please. So I want to end with just thinking about some of these big picture ethical considerations. So, as we said, consent is kind of the legal way to get it done. It's the easiest sort of mechanism. It's the way that it's okay. You get somebody's informed consent. You give them their own information and let them do the sharing. And that's sort of it's the mechanism that exists in the law that's easy to get done. But management in a way that protects patients can be difficult. So, for example, if you're thinking about keeping data for long term, if you're thinking about sharing data, putting data in a system that would allow different people to access it for different purposes beyond just a treatment encounter, just, you know, I'm sharing information with this person to give you this service and they're going to tell me if you're okay or not, you know, that it's sort of a limited treatment versus a more long-term trying to understand if this made a difference, what the outcomes were. That can be more difficult. And so, you know, your perception of risk when you give consent for something for treatment is different than sort of if you're giving consent more broadly for my information to be out there in perpetuity. So as landscapes change, as sort of things change that are going to change your perception of risk as an individual, it would be important to go back and see, do you still consent? You know, are you still okay with us having this information? So consider putting in a re-consent process. And also it can be really challenging to explain in a way that people can understand so that consent is really informed what the purpose of the data is beyond treatment, payment, healthcare operations, or beyond you getting individual social services data. So making sure that the person who's consenting really understands what you're talking about when you say something like value-based purchasing or, you know, community benefit or something is important. So, you know, the standard for consent is a reasonable person standard, the legal standard. And that might not be enough, you know, yes, you can say we've covered our legal basis, you know, we've covered our butts on the law because a reasonable person would find that this information is enough that we need to understand, you know, what the information is being shared for, and therefore a consent or authorization is valid. You know, that's not the same thing as the person who's giving the authorization really understands, you know, what the implications of this are, you know, what the risk of re-identification is, you know, what the risks are if things change, like, for example, the ACA is repealed and people can be discriminated against based on pre-existing conditions again. That changes, you know, the risk to somebody of having their information out there. So ethically, you know, more might be required than simply what the reasonable person standard will allow. And so these non-consent models that HHS is trying to facilitate to sort of expand the things that can be disclosed, you know, without particular authorization, without the person specifically authorizing that disclosure, are easier and quicker. And you know, building models to allow that, you know, should definitely make sense. But you always have to be careful that you have that the buy-in from the patient, that awareness, that understanding and consent, because you don't want to cause distrust and non-participation in the social services or in the networks that you want to, that are supposed to, you know, support people if their information has been taken and shared and sold and used in a way that they didn't anticipate and didn't want. And so that's a difficult balance that has to be struck. So I'll leave it there. Thanks, Bethany.
Thank you, Lara. You're trained in this as a professor, and so she definitely managed to get information in. In the meantime, yeah, and it's very important information that everyone shared. So I didn't want to cut anyone off. And all these slides will be shared. We did, April, Danielle, and I were in the background managing the Q&A, and we do have 2 questions that we're going to lift up, but we want to make sure everyone in the audience knows that not only do we thank you for attending today along with our subject matter experts, but we will try to follow up on the questions that we don't get to. So I'm going to ask April to unmute so that she can pose the 2 questions, and thank everyone for just hanging out with us for just 5 more minutes so we can get at least those 2 questions lifted up.
Hi, thanks so much. I did receive a question for either Paul or Jess, and the question is, have either of you received or have any additional information about any other MLPs or other civil legal service programs that has interacted with the Integrated Health Networks in St. Louis?
Yeah, our medical legal partnership it is active, especially in the Eastern region. So we connect with them in our state on things like Medicaid expansion, on you know, just any sort of state level legal issue that we are all aligned on. In the past also has been like Medicaid termination for people who are incarcerated. Our state terminates Medicaid. So it has looked more like at a policy level, but we have had discussions and conversations about exploring something more tactical where MLPs can be embedded within the health center structure.
Okay, perfect. And has IHN led to funding opportunities for the social service providers who are accepting referrals as a part of the network?
It's a good question, not yet. But I think that one of the advantages that Paul had mentioned about how we've structured our collaborative is really unique. It's not just a hospital system purchasing a data platform like Unite Us and then dumping patients. The IHN is very serious about that because we've had a history of patient dumping in the St. Louis region that have threatened the economic health of our health centers. So this collaborative approach gives us a platform to have a conversation about it rather than just reacting to it happening to us.
Thanks, Jess. And April's just checking to see if we have anyone that we can sneak in for either Lara or Paul. Since I asked people to hang tight for 5 more minutes, we want to max it out. April, do you have anyone that came in as well, just that we can squeeze in for Lara or Paul?
Let's see here. Can we just share a little more information about how we can follow up with referring providers or referring to providers about outcomes of an MLP client case without obtaining the written consent of the client or speak a little more in reference to the disclosures in reference to like our current conditions?
Lara, I don't know if you have like high level points to make about that one.
Well, I think you would need consent for the legal side, for the confidentiality side of things. But it can be part of the intake. It can be part of the intake of the patient if they've been referred as part of your services. You get permission to tell their provider just the outcome. But I think you can't do it. I think, and that sort of depends what the state law on confidentiality is and the rules that apply to lawyers. That's where it's not a HIPAA thing anymore. It's not a medical privacy issue anymore. It's a sort of legal confidentiality requirement. But typically, you would get permission and just have the patient, have the client agree to whatever the boundaries are. You're just going to tell them that it's been satisfied, or you're just going to tell them that it's been, that they've received the service, and not go into any more detail than that about what your legal outcome is. But I think it is something that the client would have to agree to.
Yeah, and I'll just add real quickly there are some population level so how can you use this information, right, in a de-identified or aggregated way to sort of inform what's working, or where we need to invest more money in additional services or resources. Most of that can be done, right, sort of in a way that both protects an individual and is able to meet some of those bigger questions about impact and resource allocation. Although like we highlighted in our presentation, there are still some ethical conversations, some ethical considerations about population level data and how that information is used to inform policy and resource allocation that people need to be mindful of. And I guess on the consent piece, right, and Jess and I were just talking about this too, consent seems like the sort of thing that can become burdensome or confusing. I think some of the newer referral platforms, I think Unite Us does a very good job of making it pretty easy for you to obtain that informed consent in a variety of different ways. But trying to, but if anything, we need to get a little bit more robust and a little more stringent around it, especially when we're talking about folks who have records that they may not want to be shared across providers who may unfairly punish them for having a criminal record, even if it has nothing to do with them getting access to food services or medical services. And so I think the tensions are real, especially from a provider standpoint. And I know that there is concern about people falling through the cracks if there are too many hurdles to jump through. But I think that's why having an approach that is as community-centered and as partnership-focused as possible will really help people navigate the complexity of those concerns, both from a kind of a system point of view, but also making sure that the complexity of an individual situation isn't sort of smushed, which is a very technical term, by some of these processes.
You're right. It's a technical term. It's a highly technical term. I actually appreciate you ending on that point, Paul, Lara, Jess. Can't thank you all enough for sharing time with us today and extending it to take a few questions. For the audience members, same to you all. We know you're extremely busy and really appreciate you all engaging with us. For the questions we didn't get to, I think there were also some comments in the chat box. We'll try to get some questions and feedback from our panelists today, and then circle back with a recording when we follow up and close out. As a heads up, we do have one last webinar for the 5-part series for the MLP Toolkit. And that is where, this is why I like that Paul ended on his point, we're moving to the systems level change. So really moving upstream to address the social determinants of health and health equity at the policy level. So we hope you'll join us as soon as that registration link goes live. We're still just making sure we've got all of our speakers ready to go and in place, because folks are really busy out there. And we understand and appreciate that as well. So we hope you'll join us next time. Thank you, thank you, thank you. Don't forget to fill out the survey at the end. We've built some resources for folks. Paul and Lara also shared some documents that we'll follow up on, including a rule change that you'll be able to comment on by May 6th. So we will see you next time. Thank you all again for joining us, and have a great day. Stay safe out there. Bye-bye.